Yeah, so welcome everyone. This is the newest edition of the Global Medical Physics Education Lecture Series. We're very lucky to have Dr. Travis Salzillo here discussing MRI-guided radiation therapy. Actually, when we put out a survey about a year, 2 years ago, a lot of people actually requested this topic. So we're very lucky to have someone who is very, very well placed to speak on this topic. So yeah, Travis is a old time colleague of mine. He did his bachelor's in physics at Tarleton State in Texas. He then joined MD Anderson, where he did a PhD in medical physics, then a postdoc in medical physics, where he worked primarily with the Unity MRI Linac, and then a clinical training residency in medical physics, and is now faculty of medical physics there in the radiation physics department, specifically focusing on central nervous system tumors. So yeah, let me turn it over to Travis and yeah, look forward to a nice lecture on MR guided therapy.
Great. Well, thank you for having me and for everybody's time. It's good to hear that this has been, a highly requested series. It gives me pretty high optimism that the future of medical physics, especially radiation and image-guided radiation therapy, has a place for MR-guided. Primarily, you will find these systems in North America and China and Europe, but I know over time, as the technology becomes more accessible, we'll start to see it in some of these other countries that have developing radiation oncology, um, uh, fields and hospitals. And I hope today I'll kind of give you some good use cases for why it would be especially useful in certain types of treatment. All right, let's see. Here we go. So just as a brief outline, I'll give a high-level overview of MR-guided radiation therapy. I'll talk about two of the system designs. There is a third and potentially a fourth out there, but these are the primary two when this first technology first started to hit the field. We primarily work with the Alexa Unity at MD Anderson, but I've collaborated with several colleagues who have worked with the V-Ray system, so I can give a few slides about that. I'll talk about some of the clinical workflows, so how this technology is actually implemented clinically. Talk specifically about some of the MR imaging protocols, because that is what gives this technology its strength and distinguishes it from your run-of-the-mill external beam linear accelerators. And then if we have time, we'll go more into the physics. I think we'll see if we can get there. We'll talk a little bit about the magnetic field effects on dosimetry and QA, but I think the first four bullet points are really the most important and most high yielding from an educational point of view. So just as a brief introduction, radiation therapy has, from the past few decades, benefited greatly from image guidance. And it wasn't until the late 90s, 1990s, that positional accuracy was mainly achieved by placing skin markings or markings on the skin, which, as a result, to ensure target coverage, you had to use very large margins and different types of immobilization. This leads to the irradiation of a large amount of surrounding normal tissue, but it's what it took because you only had external ways to align the patient. By the 1960, in a very early development, the first onboard X-ray tube was reported in the Netherlands. It was a retractable X-ray unit built within the head of the Linac the Netherlands one actually, it was not in the head of the Linac, it was orthogonal, but Stanford also developed one where they had imaging within the head of the Linac itself. The really difficult part about this, until the late 90s, was that we had to use film for image guidance. So unlike diagnostic imaging, whenever you first acquire films, you can take them to the film lab, you can develop them, and then the radiologist can read them more or less at their leisure and report back, later that day or the following days. When you have a patient on the table, you don't really have the time to develop several films that have been imaged, in real time. That's a very laborious process. and it would significantly lengthen treatment times. So that's kind of what kept the image guidance kind of at bay. But in the 1990s, digital X-ray detectors started becoming, developed and used. And it was the electronic portable imaging devices that really revolutionized image guidance. In this case, you could acquire an image, and after a little bit of processing time, you could get that image on your computer right there and then and make any positional changes that you needed to. So by the early 2000s, you had onboard cone beam CTs and CT on rail devices. And then you also had surface guidance, which used either infrared or some visible light with speckled pattern to look at real-time changes in the patient's surface. So it's not quite internal anatomy that you're imaging, but it still is very useful for making sure the patient doesn't move throughout the treatment. So these technologies are great for localizing targets that move rigidly with bone, because with cone beam and X-ray, that's really all you can see to when it comes to onboard. Modern CT scanners have a bit better soft tissue resolution. There's really state-of-the-art developments, such as the Variant has just released one. I'm trying to remember the name of it. It's not hypervision, but suffice to say, there have been inroads in improving soft tissue resolution with CT, but they're still limited for a lot of the targets. And a good example I have here, within the CNS field, we do a lot of spine irradiations, vertebral body irradiations. And one thing we really care about is the spinal cord. You can see on the left side, you can see the bone exquisitely, and you can see it delineated from the surrounding soft tissue. And in the middle, you have your canal, your spinal canal. Now, what we really care about in the canal is the spinal cord, and that cord actually floats freely within the CSF fluid within that spinal canal. So if you care about reducing dose to this and you want to make sure your cord is lined outside of the target region, if you only have onboard CT, you have a lot more space that you have to worry about, even though the cord only takes up, about half the area. And you can see here in the MRI, you have exquisite detail on the cord surrounding spinal canal. And so this is kind of one example use case, but really you can expand it to any soft tissue anatomy that surrounds tissue targets and lesions, such as abdominal tumors or GU tumors, things like that. Oligometastatic disease when you have it in muscle. Anytime you have either your target or your organs at risk that surround it that are embedded in soft tissue, MR guidance will greatly improve the localization of those tissues. The last thing that MR offers that X-ray doesn't is that real-time imaging typically is not done with X-ray. You can do fluoroscopy-based image guidance where you're constantly acquiring X-rays to see if the target is moving or if the patient moves. But that, of course, adds additional dose. And sometimes you can't acquire fluoroscopy at the same time as you're beaming on. Some systems allow you to, but not everyone does. But it's just something that's not really typically done unless you are specifically looking at a target that moves, such as a thoracic treatment. But at the end of the day, you can achieve this level of real-time imaging a lot easier and a lot safer with MR than you can with CT. So that's kind of the motivation of why MR would make a really good onboard image guidance tool. So in the late 2000s, when all this other technology was starting to reach a clinic, there was a lot of developmental work for implementing a hybrid MRI linear accelerator or an onboard MRI. The first patient treated on the V-Ray system was in 2014 at Washington University in the US. And the first patient treated on the Unity was in 2017 at Utrecht in the Netherlands. And that's where a lot of the engineering work and technological development happened and is happening is at Utrecht. A lot of the scientists and engineers involved with developing it worked here in the early 2000s. So one nice thing about the Elekta system is that there is a built-in infrastructure, because Elekta sells units that are not just MR guided. They have afterloaders for brachytherapy. They have their own external beam linear accelerators that are not MR. So they have this organizational infrastructure that lends itself to creating this consortium really naturally. You had a lot of scientists, a lot of physicists, a lot of radiation oncologists that were familiar with Elekta. So recruiting them into this consortium where you can share research and clinical protocols, clinical development projects. It really gave this a very nice platform for data sharing and for clinical use sharing. So in the MR-Linac or in the Elekta, they call that the MR-Linac Consortium. Momentum is the platform that gathers data if users want to submit it for large-scale data processing and data mining, deep learning applications, things like that. And the other good thing about Elekta is that they partner with a very well-known, well-established MR side of things with Philips. So as Philips develops MR improvements in MR, with new pulse sequences, new types of reconstruction, that can be ported over to the MR-Linac. So you have, developments on both the Elekta side from the linear accelerator technology and from Philips for the MR technology, which is really nice. So one thing, or one study that I want to highlight on the ViewRay side, which has been fascinating to follow. As I mentioned, MR guidance has lent itself really well to abdominal tumors, specifically pancreatic cancers. The reason for this is whenever you try to treat a pancreatic cancer, if you ever looked at a cone beam CT or a CT on rails, if they're being treated with that, seeing the tumors and seeing the delineation of the tumor within the pancreas and then the pancreas within the other abdominal organs at risk, such as the stomach, the duodenum, the small intestine, is very, very challenging. So this was the ideal use case, probably the highest yield way to start testing this technology. And another good reason for this is because pancreatic cancer itself is such a aggressive disease that the impacts of therapeutic outcomes and improvements and such would be vast, would be huge. So this trial looking at pancreatic cancer outcomes with the MR-Linac technology using the onboard imaging system, as well as potentially using the adaptive platform, which I'll talk about later, the ability to use the MR image of the day and adapt your treatment plan. And they demonstrated that the treatment outcomes, the overall survival of this, far exceeded the standard of care. So this was one of the landmark studies that came out back in 2023, looking at the first large-scale treatments of pancreatic cancer with MR-Linac technology. On the Elekta side, this was from the consortium meeting last year in Singapore. These were slides that were represented, but they were first at the Astro, an award-winning presentation at Astro, and they were looking at glioma or glioblastoma treatments. And one really fascinating thing was that you were able to track the lesion itself within the brain throughout the 30 fraction treatments. Now, this is important because whenever you're treating gliomas, again, you can't see the tumor within the brain itself. So usually, fairly large margins are incorporated into the treatment plan. Well, here they tested the ability to reduce these margins significantly. I think that, 5 millimeters. And they only had 4%, an incidence of 4% marginal failure rates, meaning they reduced their margins 5 millimeters and the recurrence rate or the treatment fails around the tumor itself only happened 4% of the time, which is phenomenal. That's like unheard of whenever you talk about reducing margins like that. So this is another really good use case of how you could spare a large amount of normal tissue and still achieve the standard of care outcomes as you would with a normal conventional external beam unit. Oops. All right, so that's a brief introduction, kind of the idea of why MR-Linac technology would be impactful in several different fields of radiation oncology. So we'll talk about some of the technical details. The ViewRay being the OG MR-Linac, we can talk about that first. And I'll give a brief disclaimer that, again, I don't work personally with this technology, so this is my understanding of it. If people have their own expertise and want to correct in the chat, or if there's something you hear, take that with the slightest grain of salt. But I do have some, pedagogical experience with it. So this started actually as a tri-cobalt system coupled with a 0.35 Tesla Siemens MR scanner. And so that's important for two reasons. The first being is a cobalt system. Cobalt, you'll see in a lot of older generation linear accelerators or linear accelerators that have been used for a very long period of time. And they're useful in terms of their stability. They last a very long time. You obviously need to change the source every 10 years or so, 5 to 10 years. But the other technology, the associated technology to produce the beam that you would normally in a linear accelerator, is not needed. And so, if we talk about porting these technologies to countries or clinics that are still developing or need just infrastructure, period, this is a really attractive option because you have a cobalt system. The other side of this is that it uses a 0.35 Tesla Siemens scanner. And again, for the purposes of creating this magnetic field, it's not as intensive as trying to upkeep a 1.5 Tesla or 3 Tesla scanner that you see in a lot of diagnostic clinics. Another reason that this is attractive, and we'll talk about this a bit later, is because the low magnetic field is sufficient enough to give you decent image quality to still visualize, your soft tissue contrast that you want, but it influences the radiation a lot less than some of your higher field systems like the Electa Unity, which implements a 1.5 Tesla scanner. These systems, the tri-cobalt systems, were first introduced at WashU, as I mentioned earlier, but also at Wisconsin and at UCLA. So this is kind of the what it looks like now. As I mentioned, the more modern systems actually replace your tri-cobalt system with a linear accelerator. So there are advantages to that. Mainly the treatment times are a little quicker, and you have a bit more flexibility when it comes to your dose distributions. But modern ones, as I mentioned now, you utilize a linear accelerator over the cobalt-based radiation. This is a system design. It uses a magnetron as its accelerating, or as its power amplification for the acceleration of the electrons. It has a linear accelerator output here, and that is orthogonal to the magnetic field, the high field magnetic field that runs in the transverse direction. All the other systems are pretty typical what you'd find in these linear accelerator-based systems, like a circulator. You have your MLCs, you have your electron gun, so on and so forth. As I mentioned, it uses a low field superconducting magnet, and it has a split bore that allows the linear accelerator to rotate around the magnet. So this gap here is where you would find the actual output of the radiation. You have very good homogeneity, largely in part, again, because of your low field magnet. And you have pretty good gradient coils to achieve the level of image quality that you would want in a clinical system. This is just a kind of an overview of what the magnetic field gradients look like. Really what you need to take away from this is it is very homogeneous, from all views. The coil system for the Meridian is very good when compared to other units. They utilize obviously the body coil, which is within the system itself, but then they also have surface coils and dedicated head and neck coils, which conform very well to the anatomy of the patient. And so the better your conformality, the higher your image quality will be, especially when you already have a low field magnet to begin with. These are multi-channel as well, which helps with acceleration. So I will say that the surface coil or the RF coil, the transceiver coils for these are exquisite. So kudos to Meridian for developing them. Again, this is the head coil. Now on the Unity side, one that I'm a little more familiar with, you'll see a very similar linear accelerator design. This is never a cobalt system. It had always started with a linear accelerator. But again, you have a magnetron for your power amplification, MLCs, and that rotates around the bore of the magnet. So some technical things about this. It's one energy. It's 7 MV, and it's a flattening filter free beam. So you can achieve fairly high dose rates, but it is a non-flattened beam profile. Your field size is fairly limited. On typical linear accelerators, you can achieve 40 by 40 fields pretty easily, but in the transverse direction, you only have 22 centimeters. So when it comes to treating long targets, like if you're doing a head and neck treatment where you're trying to include lymph nodes in the neck, as well as the gross tumor, you have to be a little careful with where you place isocenter to make sure you can capture everything within that 22 centimeters. It uses step and shoot IMRT. This is really good for your dose modulation. It is not the best when it comes to the treatment time, the delivery time. I will say in that very lately, VMAT has started to become available on a research platform. There have been a lot of researchers that have been using non-clinical packages to basically hack the linear accelerator to treat in a VMAT style pattern. And I would say that's on the horizon of being released. As somebody not from Alexa, it seems like it should be something that would be on the horizon of being released fairly soon. So VMAT would honestly revolutionize the Unity system because your treatment times would be vastly increased. Your dose rate is 425 MU per minute. You can spin the gantry around at 6 rotations per minute. And your collimator, one downside about this compared to external beam units is you have a fixed collimator at 90 degrees. So that is a slight, downside when it comes to modulation, but you still achieve very good modulation regardless. But just something to keep in mind. This is just like a schematic of what it would look like. It's, again, very similar to what you saw with the V-Ray linear accelerator system. Again, you have your shielding coils, your primary coils, everything you would expect in an MRI you have on your linear accelerator. The one thing also you have to worry about is you have a cryostat that does limit your field angles. You have a very, very small area that you tell the beam not to treat through because you don't want to be treating through the cryostat. This is a 1.5 Tesla magnet, which is incredible when it comes to image quality, and it allows you to really investigate more of the quantitative and functional types of MR scanning that are challenging to do with a low field magnet. You'll see here that it's not impossible, but the 1.5 Tesla gives you the SNR that really unlocks things like diffusion weighted imaging, relaxometry based imaging like T1 mapping and T2 mapping, so on and so forth. And we'll talk about that later. You have a three-dimensional gradient coil system. You have your body coil again that exists within the magnet, which you can see here. Well, this is a surface coil. That's not the body coils are within the table. But then you also have these anterior and posterior coils. I will say that personally working with these, like this is really where I think the high yield impacts would be. If we could get better coils, that's my wish list when it comes to these systems. You have such a high magnetic field, but you lose a lot of your SNR because the coils are of a surface coil based approach, which are non-conformal to the body. They exist within this circular apparatus that you can lower towards the patient, but it's not like the flex coils that you might see in a Siemens system, for example. So there's a lot of room, opportunity space for coil development for this system. One thing about this coil is it is radiolucent, so you can shoot through it. You don't have to worry about avoiding the coil whenever you're trying to plan your fields for treatment. Just as a brief kind of overview of how we installed it at MD Anderson, our installation process. The clinical version installation was completed in 2018. The commissioning process happened shortly after that by physics. And then the nice thing is that coincided really well with the FDA approval that happened in 2018, in December of 2018. And so we had a very quick turnaround when we were able to first start treating patients on clinical trials starting in January of 2019. And we were the first site in North America to treat a patient with this Unity system, in the US. And now it's, there's several systems within the US, spread out across the country and across internationally. So the number of patients that are treated with this system is very high. Let's see. I think I have a video here. I'll play this. This kind of is a little time lapse. Yeah, 2-minute build. I'm gonna mute it too. It's music, and I don't know if it's glitchy or not, but the visuals are more important than the music. So this is a vault that we dedicated to it. An interesting thing you'll see here is because we have an MRI, it's not sufficient just to have your typical concrete vault. You have to have that for the radiation, the high energy radiation. But then you also have to build an RF cage within the vault itself that basically keeps RF interference out, so your image quality isn't compromised. So you'll see here first, they're in the vault. The birdcage has not been put up, and right now they're they're building the linear accelerator system first. So that's the gantry that they're putting on. You'll see shortly that they're going to start putting components on here, as I mentioned, like the magnetron, the imager. So there's an MV imager. There's no KV like orthogonal KV imagers, but there is an in-plane MV imager. This is the MRI, the magnet itself. Very, very heavy. They had to take out a wall of the clinic to bring it in. And then you can see here, it kind of slides in between inside of the linear accelerator. And there is I believe, a small gap that the linear accelerator kind of fits between, kind of what I showed with the V-Ray Cobalt system. So this is a modulator cabinet and a few other things. Yeah, they didn't really show the birdcage. Unfortunately, this is a finished product. I wonder if there's a way I'll let it finish and see if we can identify the point at which you see it. But yeah, this is basically a room within a room. So this is a room that has a Faraday cage around it that keeps RF interference out. And then if you can step out of this room into the vault itself, and that's where all your lead shielding is and your lead door, your concrete shielding and your lead door to obviously shield from the high field radiation. Let me see if I'm not going to belabor this, but if I can identify where they put it up. Oh, maybe that's it right there. That would be a good place to stop this. I guess I got it right here. So this is the MR vault, if you will. So it's an MR vault within a radiation accelerator vault. So this is the MR vault itself. This is not the concrete. So this has all the Faraday caging within it. Okay, so that's the technical aspects, some of the nuts and bolts of it, if you will. So now we can talk about the clinical workflows. From the V-Ray side, the unique thing about V-Ray is you fully adapt every fraction. So you image, you recontour every fraction. I believe you can propagate contours, but there is a recontouring step that needs to be achieved during every fraction. You predict the dose, or I believe this is basically applying your reference dose on your new image of the day with the new contours, and then you re-optimize the plan to get the dosimetry as you want. So you have the necessary target coverage and minimizing OAR dose, surrounding OAR dose. There's a brief QA step that's done using a secondary calculation, and then you do. After that's passed, you apply real-time imaging with the MRI to make sure that the positioning of the target hasn't moved. And then you treat, and you can gate your beam based off what you see in real time of the MRI. Really brief note about this patient-specific QA. We put the patient on the table and we image them and we create a plan. It's not possible to deliver that plan using, a phantom-based patient-specific QA, because then you'd have to move the patient out, and now your patient and geometry and your plan geometry is completely different when then you put the patient back in. So unlike external beam systems, whenever a plan is created, then you use a phantom to test the plan. That could be like an arc check, for example. And then you can you do gamma analysis and you say, okay, the plan is deliverable. That step before treatment is not possible with MR-Linacs. When we first started at our institution, we would do retrospective patient-specific QA. Basically, at the end of the day, after all the patients were done, the phantom-based patient-specific QA would be performed and ensure that the plan that was delivered that day was what we had expected it to be based off the treatment planning system. We did that at every fraction, and then we have now started just doing it for the highly adaptive fractions. And when I say highly adaptive, you'll see what I mean here in a second. But there's increasing evidence that demonstrates that any type of adaptive plan you do with these systems has a very, very, very high likelihood of passing patient-specific QA. So the use of secondary MU calculations has proven to be sufficient for patient safety before these treatments, which is good. So on the Unity side, it's a very similar workflow. So these first three steps are kind of what you would expect with conventional external beam treatments. You get an MR simulation. You often have a CT simulation as well for your electron density calculations. And then you do your treatment planning beforehand. But once your treatment plan is ready and you come to the first fraction of the treatment, you set the patient up after the daily QA, you acquire your images, and you register these images to your reference images. And your reference images are the ones that were acquired at the time of simulation. And then you can adapt the plan, very similar to what I talked about with the V-Ray. Now, this plan adaptation has multiple flavors, which I'll show here in a second. But another useful thing that has just blessed the Unity system after a long time of waiting is this motion monitoring. We have had motion monitoring because motion monitoring can be achieved with any type of cine-based imaging, real-time imaging. That's never been an issue, but we have now just recently been able to gate the beam on the Unity system, which was something that I believe V-Ray had, since its inception, or at least, as long as I've known it being in existence for. But I can say, finally, after several years, Unity has achieved that ability to gate the beam based off your motion monitoring. So it's no longer just observational motion monitoring. Now it is active, beam halting motion monitoring if the patient moves or if the target is moving itself. This is kind of an idea of what the personnel that's required at different steps. So we have two RTTs or radiation technologists, radiation therapists, I should say. So, this terminology is different for every country or every institution, but two radiation therapists that are there for the entirety of the treatment. They're responsible for setting up and imaging the patient. We have a physicist there that at the beginning, it was a dedicated physicist that was there the entire time, and their responsibility was registering the images and basically taking the reference plan and importing it onto the image of the day. If there is recontouring that was necessary, especially of the targets, then the physician would recontour, and the plan would be adapted and re-optimized and approved by the physician. Once everything is set up from the plan adaptation point of view and the contouring point of view, then the plan is delivered, and the physicist will be around in case something happens, if the patient moves and needs to be reset up, or if there's an interlock that needs to be addressed. But they're hands off at that point. The therapists take over and continue with the delivery of the treatment. The physicist role is a little variable. As this technology is becoming, more standard, I should not say standard of care, but more common, and as we treat more and more patients, the therapists can take on a larger role within this process. For example, for external beam treatments, the therapist often will register the images. They won't adapt plans, obviously, but they'll register them. They'll check the contours, make sure that they align to the anatomy of the day. So on the MR-Linac system, that's also something that can be done by a therapist conceivably. The replanning is something that maybe the therapist, if you can train them, if it's something that doesn't require a high level of clinical judgment in terms of how does the dose you know, how does the dose coverage compare to what it was before, and is it acceptable? That's something that maybe dosimetry could fill in or could contribute to. But basically, it's this ongoing evolution of the roles of these different personnel, and really the expansion of the roles of the technologists or the therapists. Because the more of a role they take on, the higher throughput these treatments will be. Just because you don't need the personality, the high level expertise at every single treatment. From the MR simulation point of view, unlike diagnostic MRI, the simulation requires the patient to be in the same position that they'll be during treatment. So we use the exact same immobilization equipment that will be used during treatment. This is something to consider because there's immobilization equipment that we do for CT simulation that utilizes some types of metal that we don't want to bring into the MRI, both from a ferromagnetic point of view, but also an image quality point of view. So your equipment might have to change, for example, from carbon fiber to like a plexiglass material. But this ensures that the geometry between simulation and treatment is consistent. Now, the beauty of the plan adaptation is it doesn't have to be, but your plan adaptation process will be significantly quicker the more consistent your geometry is between your reference plan that you planned on your simulation image and your geometry of the day that you image, during each fraction. The imaging can occur either on the MR-Linac itself or on a dedicated MR simulator. So we've done both. Because we now have a high treatment volume on our MR-Linac, we do less and less MR simulations on it. But it is something that you're capable of doing is actually performing the MR simulation itself on the MR-Linac. The planning for Unity treatments is carried out with Monaco. This is the same type of treatment planning system that is used for conventional Elekta external beam treatment planning. It's just that this version of Monaco incorporates the magnetic field within it so that you can accurately model the dosimetry even under the influences of the high magnetic field. The planner, whenever they get the images, they set final isocenter, they set the beam angles, they set the maximum number of control points or the modulation of the plan. And then the treatment plan itself, the treatment planning system, automatically sets the positions of the jaws, the MLCs, and then the MU per control point. And this can be an iterative process. So it's based on a cost function. You set, plan objectives, and the closer your plan objectives are to being achieved, the more the plan optimizers, the more time the optimizer spends on, optimizing other areas of the plan. But the nice thing is it's a nice hybrid between your automated planning side of things and the manual dosimetrist control of the treatment planning system. It's very user friendly, is basically what I'm getting at. So during each treatment fraction, another interesting thing, at least for the Unity, I don't know for the V-Ray if this is the case, but at least for the Unity, one really unique thing is that the couch does not move. It moves in and out. So you set the isocenter and you set the index on the couch where you want the isocenter. You set the index on the couch where you want it to be at isocenter. So like if you lay the patient down and you're treating that the target is at 20, you'll send the couch to 20 at the beam isocenter. But there's no lateral. There's movement of the couch. There's no up and down movement of the couch, and there's no roll or yaw or pitch of the couch. So this is unusual because in conventional treatments, that's what allows you to match your geometry of the day to your simulation geometry. But we don't have that in the Unity. The way you achieve that that manipulation of the geometry is you actually manipulate the plan itself. You don't manipulate the positioning of the patient. So instead of moving the patient to match the plan, you change the plan to match the patient geometry. And the way we do that again is with online adaptation. So this is my my kindergarten sketch of what this looks like. The couch is positioned precisely in, as I mentioned, in conventional radiation therapy. You have onboard X-rays to compare the geometry, and then any discrepancies are carried out by moving the couch. MR guided, you change the plan. I guess I talked about this in the previous slide, so we don't have to belabor this fact. There's two types of plan adaptation on the Unity. There's adapt to position and there's adapt to shape. These are the low level and high level adaptation, plan adaptation I mentioned earlier. With adapt to position, essentially what it boils down to is that everything looks the same. It's just that your isocenter or your treatment target is offset by a few centimeters in any direction. And so you fuse your images, you calculate how much it's offset by, and you basically shift your MLCs and do a small amount of plan reoptimization to do a pseudo shift of the plan. With adapt to shape, if your plan geometry or image geometry is significantly different, if your tumor has shrunk, if it's grown, if you have surrounding organs at risk that have moved, for example, if you're treating prostate, if your bladder is bigger, if your stomach is more filled, if your intestines have more gas, you often will have to deform your contours because they don't match what they look like on the simulation image. That recontouring requires a full plan reoptimization, and that is a pretty long process, but it ensures that your dosimetry really matches what you wanted during the planning. There's different degrees of plan adaptation in ATP and ATS. It's a little too technical to go into too much detail, but essentially it boils down to you can move your MLCs in unison. So like if your target is 2 millimeters up, you can just move your MLCs 2 millimeters up. You can adapt the MLC geometry to change to conform to the shape of the target. And then you can optimize both the number of control points as well as the weights of the control points based off the dosimetry of the day. I don't want to get into too much detail, because of just kind of the too technical from an overview perspective, an overview talk, but also I recognize we're 45 minutes in and I still want to get to a few other things. Once adaptive plan is created and it meets the requisite clinical goals and the physician approves it, the physicist will review it and approve it, and then treatment can be delivered. Now, imaging can be performed throughout treatment. And the nice thing about this is, obviously, if you're trying to do motion management, you can do real-time MRI and look at your treatment position, your target position, several times per second with a very high frame rate. Or if you have a target that does not move, for example, if you're treating a head and neck and the patient is in a thermoplastic mask, and you have a very high degree of confidence that your target is not going to move once the patient is set up, then you can use that treatment time to acquire different types of imaging that you might want to do as part of a follow-up analysis. So if you want to look at, a diffusion-weighted imaging to measure diffusion, if you want to look at T1 mapping, T2 mapping, if you want to do a type of functional MRI, you have time during the treatment itself to image whatever you want to image if you don't care about imaging motion. So from the motion management perspective, as I said, this is a pretty new development. You can now do real-time gating. So as your target moves, if it moves out of a position like far enough from isocenter that you are losing target coverage, your beam will automatically stop until the target is moved back into it. So a common way or common time you see this is during respiration. If you want to try to implement breath holds, you can have the beam on whenever the patient's holding their breath and the target is in the spot that you want it to be at. And whenever they release and exhale, the real-time MRI, the real-time imaging will detect that, stop the beam until the target is back into its location that you intend it to be in. Another way you see this is for prostate treatments. As your bladder fills, it pushes your prostate, further away. And so if you have a long treatment, then, halfway through treatment, you might notice, okay, my prostate's moved a few millimeters from where it started. Let's stop the beam and let's do some form of plane adaptation to recenter our isocenter onto the prostate. This is kind of what it looks like. I don't think I have a video of it, unfortunately, but this is like your template that you're tracking. You have this treatment, your tolerance or your ITV, if you will, and if your target in the blue moves outside of it, your beam will stop. So with the last few minutes, I'll just talk about some of the imaging protocols. And so we'll forego the QA. That's the boring stuff anyway. And I can talk about that. I can answer questions about that if we need to. But from the meridian side, the ViewRay side, the majority of the imaging uses this true FISP sequence. So it's a balanced, steady state, free precession. It is a very good real-time imaging technique. And Klaus Scheffler is the person to credit for developing this sequence. It's the most SNR efficient sequence you can have. It uses every bit of magnetization that you can, that's available. I'll leave this. I think there's an MRI talk that talks about the MR physics of it, but this is what the pulse sequence looks like. And this is kind of an example of the imaging you have and your different T2 over T1 values, because that's ultimately what you're imaging. It's not a T2 weighted image. It's not a T1 weighted image. It's a T2 over T1 weighted image. This is a pretty interesting one of a few on recent developments of getting DWI imageable, if we can use that word, on the low field tri-cobalt or ViewRay linear accelerator system. So it's a 0.35 Tesla. Functional based and quantitative based imaging is very challenging because you have very limited SNR, and these types of imaging are already SNR, have a low level SNR to begin with. So you have to be careful. You have to either use long image times or fancy processing to get sufficient SNR, sufficient signal to see more than noise. But there's been a lot of work into developing this to be actually something you can image on these low field magnets. There's a few experiments or a few studies that have looked at this and look at the accuracy of your ADC maps that you're getting from this. Our host, Joe Wiegand, has been involved in several of these studies. Here you go. Here's your citation. This is one of the first in vivo, if not the first in vivo image of DWI on this low field magnet. So this in itself is like already a huge achievement because it's one thing to do this on a 1.5 or 3 Tesla system. It's another to do it on a low field magnet. It allows you to use your ViewRay technology and still acquire these really high yield, really useful functional based imaging, which again is something that is really impressive, really high impact. And then here's some advanced diffusion tensor imaging, if you will. On the Unity, we're blessed to have a 1.5 Tesla magnet, and so it's a lot easier to achieve some of these more advanced types of imaging. So your conventional MR, there's T1 weighted, there's this balanced, as we talked about earlier, this balanced type of acquisition, and then T2 weighted. These are all very conventional, very, very, standardized and kind of run-of-the-mill T1 and T2 weighting. You just appreciate like your onboard CT, if you're trying to look for this tumor in the liver versus if you have a T2 weighted image, like it's night and day. Night and day. One thing that I worked with is fat saturation based imaging. So in the head and neck region, there's a lot of fat that surrounds the anatomy, both the OARs and the tumors. And so there's fat saturation techniques to basically void signal coming from the fat so that signal from the surrounding tissues is visible. And then the same thing goes with metal. If you are trying to image metal, you want to be able to get rid of the metal artifacts from it so you can see the surrounding anatomy. There's CNA-based imaging. We talked about that in a lot of detail. Um, Diffusion-weighted based imaging looks phenomenal on these systems. This is probably one of the most researched areas on in image-guided, MR-guided radiation therapy from the imaging side. Um, this is one example from my postdoc lab where they're able to segregate responders versus non-responders, just purely based off the diffusion weighted signal, your ADC map. And you can see that, using this change in diffusion over time, if it changes by more than 7%, you have a significantly higher response rate to radiation. And I didn't really get into detail of this, but one beautiful thing about this is you can acquire these as many days as you want. You can get these um, once in the middle of treatment, you can get them once a week, you can get them every day. So the time granularity of these imaging studies is endless. And you can look at not only the quantitative MR signal at the very beginning and the very end, but you can see the dynamics of it throughout treatment. This is some relaxometry, T1 and T2 mapping done out of MSK. And I'll stop there, recognizing that we have just a few minutes left. I'm willing to stay longer. I don't know how long we can put this on for, but I'll stop here because, again, this is more of the physics aspect of it, and I don't think it's, as a physicist, not the most interesting part of this presentation. So I'll go ahead and stop there, and I'll open the forum to any questions that we might have.